The next two vignettes have to do with cancer of the colon. So let me go into a little background to help us understand them a little better. The vast majority, about 98% of the cancers that we see in the colon are adenocarcinoma. So they grow out of the mucosa. And as they do so, they can cause symptoms in two different ways. They can impinge upon the lumen. So there are symptoms that are referable to having some degree of obstruction in the lumen. And the second thing they do is they bleed. Not a gallon or two at a time, a few cc's every day, but that's the second manifestation. But these two things have very different clinical presentations for cancers that are on the right side of the colon as opposed to the left side of the colon. On the right side, to begin with, we have a bigger lumen than we have on the left, and the feces are liquid rather than solid, so it doesn't take an awful lot of space for the contents to go through, and therefore we very seldom see clinical manifestations of luminal impingement when a cancer is growing in the right side of the colon. Furthermore, when that cancer bleeds on the right side of the colon, the little bit of blood that comes from that tumor mixes with the liquid stool, becomes intimately a part of the stool. So by the time the stools become solid and the patient sees them, the blood is occult. The blood is not obvious to the patient. So in a cancer that's on the right side of the colon, all we have in the way of manifestations is the fact that the patient is bleeding a few cc's every day, and it's otherwise unaware of the fact that this is happening, and not surprisingly, the symptom, the classical presentation of a cancer on the right side of the colon is anemia. Anemia in a person in the appropriate age group, for no other explainable reason, who's then found to have occult blood in the stool. On the left side, on the other hand, we have a smaller lumen. We have feces that by then are solid feces, require more space to go through. And so we typically see on cancers of the left side of the colon signs, clinical manifestations of luminal impingement. And this can be a change in bowel habit, constipation of recent onset, and also a change in the caliber and even the shape of the stools. And I like to explain that to my students with what I call the famous toothpaste analogy. If you take a tube of toothpaste and you open it with a pair of scissors and see what's inside, you will not find a long coiled cylinder of toothpaste waiting to come out. You just find a blob of toothpaste. Well, the same is true with the left side of the colon. The feces that we are accustomed to seeing in the toilet bowl have that appearance because they've gone through the round opening of the anal sphincter. But if those feces go through a little bitty slit of lumen left because of a cancer there, or perhaps a very small lumen left in a circular fashion, then the stools are going to be flat like a ribbon, or they're going to be pencil thin, and so on. Furthermore, on the cancers on the left side, the blood that is now added to the feces are already formed, they're already solid, the blood then is added to the outside of the feces, and it's visible to the patient. So the manifestations then include also the fact that the patient recognizes the presence of blood in the stool, blood coating the outside of the stool. Well, let's read a couple of vignettes that exemplify these. We're now on vignette number 16. A 59-year-old man is referred for evaluation because he has been fainting at his job where he operates heavy machinery. He is pale and gaunt, but otherwise his physical exam is remarkable only for 4+ occult blood in the stool. The lab shows a hemoglobin of 5, classical. This is a cancer of the cecum or a cancer of the ascending colon. This is a cancer of the right side of the colon. And we make the diagnosis with endoscopy and biopsies, and obviously to get to that point in the colon, the endoscopy will have to be a colonoscopy, the full-length colonoscopy and biopsies. After that, blood transfusions to bring it up to a level where he can be safely operated on, a CT scan to see how extensive the primary is and whether it's resectable or not, and so on, and then eventually a right hemicolectomy. On the next vignette, we have the other example. Vignette number 17, a 56-year-old man has bloody bowel movements. The blood coats the outside of the stool and has been present on and off for several weeks. For the past 2 months, he's been constipated, and his stools have become of narrow caliber. Classical presentation for a cancer on the left side of the colon. This could be the sigmoid, it could be the rectum or the junction of the two rectosigmoid area in that territory. But here again, endoscopy and biopsy is what will provide a diagnosis. But the endoscopy here could be one that's easier to do. Doing a full-fledged colonoscopy all the way to the cecum is not something that every physician can do. It requires training and experience, and it's a long, somewhat complicated procedure. On the other hand, virtually any physician can handle and use the shorter fiber optic instruments, and there are two of them commonly used, the 45 cm and the 60 cm flexible sigmoidoscopic instrument. And so the first study probably in a patient with this kind of a presentation would be that flexible sigmoidoscopic examination with either the 45 or the 60 cm instrument, and the biopsies and the diagnosis. After that, a CT scan to see again the extent of the primary tumor, the presence or absence of liver mets, to decide on the appropriate surgical management. But I have to point out that before that operation is done for the cancer on the left side of the colon, the patient actually has to have the full-length colonoscopy. The entire colon has to be looked at, because these cancers are often multicentric. In fact, the figure that is often quoted is that 3% of them already have a second primary at the time the first tumor is recognized, and about 10% of them will develop a second primary later on. Well, it would be very embarrassing to do the appropriate operation for the cancer in the rectum or the sigmoid and not to do anything for the cancer in the hepatic flexure or the splenic flexure, because we never knew it was there. But frequently the way this is handled is the initial physician who sees the patient does the easy to do 45 or 60 cm flexible sigmoidoscopic exam, and the surgeon who's eventually going to do the final operation does the colonoscopy, sometimes even under the same anesthetic before the operation is done. All right, let's move on now, vignette number 18. A 77-year-old man has a colonoscopy because of rectal bleeding. A villous adenoma is found in the rectum, and several adenomatous polyps are identified in the sigmoid and descending colon. We may find in the exam questions that give us a diagnosis of some kind of a polyp or polyps in the colon. And then we'll ask us what needs to be done about them. And of course, the crux of that decision rests on whether those polyps are pre-malignant or not. So let's remind ourselves of which polyps in the colon are pre-malignant and which ones are not, and to what extent they are pre-malignant. And if we go from the kind of polyp most likely to become a cancer, it would have to be familial polyposis, or the variants like Gardner syndrome. In familial polyposis, it's virtually 100% predictable that cancer will develop, and therefore resection of all the territory that contains the polyps is mandatory, and in most cases this means the entire colon, the proctocolectomy. Next in likelihood of becoming malignant is the villous adenoma, and roughly 50% of the villous adenomas that we see if they are not resected will soon become cancer. So again, resection for villous adenoma is mandatory. And then next, also pre-malignant, although perhaps to a lesser degree, is the standard adenomatous polyp, and we remove every adenomatous polyp that a patient has. We nowadays can do that endoscopically for the most part. They can be snared and removed endoscopically, but if there are several on different locations or they are sessile, it may be necessary to do it surgically. On the other hand, if your exam question were to say that the patient has juvenile polyps or Pets-Jeger's disease, polyps of that type, or inflammatory polyps or hyperplastic polyps, None of these are pre-malignant. So if they have been diagnosed in that way, they can be left alone. Let's move on now to vignette number 19. I'm going to read the whole vignette, and then we're going to have quite a bit of analysis to do on that vignette. A 42-year-old man has suffered from chronic ulcerative colitis for 20 years. He weighs 90 pounds and has had at least 40 hospital admissions for exacerbations of the disease. Due to a recent relapse, he has been placed on high-dose steroids and Imuran. For the past 12 hours, he's had severe abdominal pain, temperature of 104, and leukocytosis. He looks ill and toxic. His abdomen is tender, particularly in the epigastric area, and he has muscle guarding and rebound. X-rays show a massively distended transverse colon, and there is gas within the wall of the colon. Now, what I did in this vignette is I included here every single indication that we have for surgery in chronic ulcerative colitis. Now, surgery is not the initial treatment for chronic ulcerative colitis. Chronic ulcerative colitis can be handled medically, and that's the way it usually is handled. But chronic ulcerative colitis, in contrast to Crohn's disease, the other inflammatory bowel disease, chronic ulcerative colitis can be cured with an operation if we need to do it, because by removing the colon, and it invariably includes removing the rectal mucosa, which is always involved in the disease, we can remove the disease. We cannot do that with regional enteritis. Crohn's disease can happen anywhere from the mouth to the anus, and so we cannot resect all the territory that might harbor regional enteritis. And therefore, surgeons are a lot less eager to operate on Crohn's disease than they are on chronic ulcerative colitis. And in fact, for Crohn's disease, we would operate only for the complications that make it mandatory: perforation, obstruction, bleeding, fistula formation. But in the case of the chronic ulcerative colitis, as illustrated in this vignette, there are a number of situations where surgery is clearly indicated. Well, let's analyze this vignette again. 42-year-old man has suffered from chronic ulcerative colitis for 20 years. That right there is already a surgical indication. Because when you go beyond that time with CUC, with chronic ulcerative colitis, you're at very high risk of developing carcinoma. So that's indication number one. We keep on reading here that he weighs 90 pounds and has had at least 40 hospital admissions for exacerbations of the disease, and there is a second indication. If the disease interferes with the nutritional status or interferes with the lifestyle of the patient, then it's better to be rid of the colon and be able to live again like a human being. And then we have the next indication right after that. Due to a recent relapse, he's been placed on high-dose steroids and Imuran. It could have been cyclosporin, some other immunosuppressant. Steroids and immunosuppressants are often used to control flare-ups of the disease. They are very effective. They do control them, but as you well know, a patient cannot be long-term on high-dose steroids or immunosuppressants without paying a very high price in terms of morbidity and even mortality. So if that's what it takes to control chronic ulcerative colitis, surgery is a better option. And then finally, the last few lines of this vignette describe that feared acute complication of the disease that we call toxic megacolon. That's what the last few lines are. The severe abdominal pain with a fever, with a very distended transverse colon, all of that description there is toxic megacolon, which requires an emergency operation. So here we have, as I pointed out, all the surgical indications for chronic ulcerative colitis. The exact operation we do will vary depending on the extent of the disease, but let me emphasize again, the rectal mucosa always has to be removed. It doesn't mean necessarily you have to have an ileostomy as the outcome of that, because there are imaginative ways to do an ileoanal anastomosis, but the rectal mucosa has to go. All right, let's move now to vignette number 20. A 27-year-old man is recovering from an appendectomy for gangrenous acute appendicitis with perforation and periappendicular abscess. He has been receiving clindamycin and tobramycin for 7 days. Let me stop right there. If you are told the patient has whatever symptoms, he's being on antibiotics, and you move right on, probably the question isn't related to the antibiotic because there was no specific information. But if a question says the very specific antibiotic the patient is getting, now we have a good possibility that may be where the problem lies. And in fact, when you hear the word clindamycin, little red flags ought to go up, because as we know, that's the one most commonly associated with the overgrowth of Clostridium difficile. So we keep on reading, and sure enough, 8 hours ago he developed watery diarrhea, crampy abdominal pain, fever, and leukocytosis. We have a vignette that is pseudomembranous enterocolitis from overgrowth of Clostridium difficile. All right, how are we going to make the diagnosis? There are 3 ways to do it. We can do stool cultures, but that takes time to get the answer back. We can do a proctosigmoidoscopic exam, which can be done right away, and if the disease is severe enough, and if it has the typical endoscopic findings, we can make the diagnosis right away. But it will not every time have the classical findings. And the third way, probably the best answer for the exam, is the identification of the toxin in the stool. And this can be done with little kits that enable that laboratory determination to be done. It's a very rapid thing that gives you the answer right away. Now, what about management? There are a couple of things that everybody agrees on the management of these. Obviously, the offending antibiotic has to be stopped. In this particular vignette is clindamycin. I might remind you, though, that other antibiotics have also been associated with this problem. So whichever is the guilty antibiotic has to be stopped. And there is also universal agreement that we should not use anti-diarrhea medications. Do not pick an answer where you give the patient Lomotil or Paregoric. That just keeps the toxin there instead of having the toxin go to the toilet. But what do we do to actually kill the Clostridium and get normal flora again? There is a little controversy there. Some people prefer vancomycin, some people prefer metronidazole, and there are even some physicians who would rather replenish the normal flora instead of using antibiotics. Probably of these 3 options, the one most commonly used is metronidazole. In fact, it's the one that I would pick for a patient of mine. But I have to alert you that the correct answer in the question could be either of those. And remember, there will not be both offered in the same question, because both vancomycin and metronidazole, for instance, would be acceptable answers. Now we're going to move to the anorectal area. Let me alert you at the very beginning that questions of anorectal disease lend themselves very well to that format of examination question that we've been talking about, that is the extended matching set. The one that begins with a list or 10 or 12 or 15 diagnoses and then follows with 10 or 15 little vignettes, very small 1-2 line vignettes, and you have to match one with the other. The reason anorectal disease lends itself to that is that there are very many conditions in the area where just 1 or 2 lines of description give you the diagnosis. So it's a good topic for this kind of question. I should add, incidentally, that this kind of question always has a common theme. In the extended matching set, you will not find broken bones and brain tumors in the same extended matching set. Well, in this case, the common theme is anorectal disease. As in other questions, it might be fever or abdominal pain or breast disease or whatever. But on the other hand, if we encounter a question from anorectal disease where the crux of the question is the management, how we're going to treat the patient, the management in that case always begins by ruling out cancer. In other words, never pick an answer where you would prescribe medication, let's say over the phone. A patient is known to have hemorrhoids, he calls in and says, I'm bleeding from the hemorrhoids, and you say, well, use these suppositories. That would not be a good answer on the exam, ever, because that patient would first have to be examined. We would have to rule out cancer before we proceed. All right, let's begin to read these vignettes. Vignette number 21. A 60-year-old man known to have hemorrhoids reports bright red blood in the toilet paper after evacuation. Vignette number 22. A 60-year-old man known to have hemorrhoids complains of anal itching and discomfort, particularly towards the end of the day. He has mild perianal pain when sitting down, finds himself sitting sideways to avoid the discomfort. Well, here is a rule for hemorrhoids, with exceptions like all of these medical rules are. But the rule is internal hemorrhoids bleed but do not hurt. External hemorrhoids hurt but do not bleed. And so if we have to match either of these, and instead of matching said, the patient reporting the bright red blood after evacuation is probably bleeding from internal hemorrhoids. The one that is complaining of pain and discomfort probably has that from external hemorrhoids. I might add the latter could also be true for an internal hemorrhoid that has prolapsed all the way and is now caught, and the anal sphincter is outside of the anal canal. It has that pressure of the sphincter on it all the time, and that tissue secretes mucus and leads on to itching and discomfort and so on. But again, probably the easiest, simplest rule is the internal ones bleed, the external ones hurt. If on the other hand either of these were to ask for the management begins by doing a rectal exam and the proctoscopic endoscopic exam to make sure that there is no cancer, and then to verify the diagnosis. Internal hemorrhoids, because they have no innervation for pain, can then be treated if needed by rubber band ligation or by laser or by other ways of destroying them. The rubber band ligation is very commonly used, and this is not the standard rubber band you would buy in a store. It's little bitty one with a special applicator that strangles the base of the hemorrhoid. If external hemorrhoids, on the other hand, were to be bothersome enough to need intervention, it would have to be a formal operation with anesthesia because they are innervated for pain. Let's move on to the next one, vignette number 23. A 23-year-old woman describes exquisite pain with defecation and blood streaks on the outside of the stools. Because of the pain, she avoids having bowel movements, and when she finally does, the stools are hard and even more painful. Physical examination cannot be done, as she refuses to allow anyone to even look into the area because of fear of precipitating the pain. This is a classical description of anal fissure. The anal fissure occurs primarily to young women, and so that's the kind of patient we'll have it. And this is a description. There is pain on defecation. Patient avoids having bowel movement. There's little streaks of blood, and you may even have that little detail that the first encounter between the patient and the physician was a disaster because the physician could never examine the patient. So if you are now, again, matching on an extended matching set, this is anal fissure. If you're asked for the management, on the other hand, we're going to have to begin by examining the patient. Obviously, in this case, under anesthesia. It couldn't be done otherwise. So under anesthesia, which could be a spinal or could be a general, we would have to look, see the anal fissure, and then do the rectal exam and the endoscopy to be sure that there isn't a cancer higher up that is in fact the one responsible for the blood. Now for the management of the condition, we can begin with conservative things like stool softeners and topical agents and so on. But our understanding of what's happening here is what dictates the type of therapy that is used. Our belief is that the anal fissure occurs because the patient has a very tight sphincter all the time. And the theory is that, in fact, all of us normally create small tears of the anal mucosa when we have bowel movements and clean ourselves. But because there is an enormous, excellent blood supply of the anal rectal area, those little things that we have all the time heal immediately. And this type of patient, on the other hand, if the sphincter is tight all the time, that cuts off the blood supply to the mucosa, and those normal little tears then do not heal, and they go on to become deeper and eventually to become painful and to bleed. And so among the topical agents used are things like nitroglycerin cream, things that will relax the sphincter. But if more aggressive therapy is required, then what we do are things designed to relax the sphincter. This could be, if it's done surgically, a lateral internal sphincterotomy or forceful dilatation. And lately another option has become available where injections of botulinum toxin can be used, again, to paralyze the sphincter. Let's move on to the next one, vignette number 24. A 28-year-old man is brought to the office by his mother. Beginning 4 months ago, he has had 3 operations done elsewhere for a perianal fistula, but after each one, the area has not healed, and in fact, the surgical wounds have become bigger. He now has multiple unhealing ulcers, fissures, and fistulas all around the anus with purulent discharge, and there are no palpable masses. This is again easy to identify. This is Crohn's disease affecting the anus. Again, as I said before, the anorectal area has an excellent blood supply, and therefore, as a rule, any operation done in that area heals very quickly and very well. And so when we have a vignette that says the operations do not heal, things keep getting worse, we immediately know this is Crohn's disease. As far as the management is concerned, we obviously have to begin by examining the patient, the rectal exam, the endoscopy, to be sure that the manifestations are not from an advanced necrotic cancer. There are cases that mimic this description. If a patient, for instance, has an extensive anorectal cancer, perhaps a squamous cell carcinoma of the anus that has become necrotic, you could have purulent discharge from that, and that certainly would not heal because it's an advancing cancer. So even though the description is good enough so that in an extended matching set we know this is Crohn's disease, in the management of a real patient, again, the examination and the appropriate biopsies would be mandatory first. And then the treatment that we do for Crohn's disease. Let's move to vignette number 25. 44-year-old man shows up in the ER at 11 p.m. with exquisite perianal pain. He cannot sit down. Reports that bowel movements are very painful and has been having chills and fever. Physical examination shows a hot, tender, red, fluctuant mass between the anus and the ischial tuberosity. This is a classic. This is an ischiorectal abscess, also known as a perirectal abscess. Well, we know that all abscesses need to be drained, and the management, therefore, would be incision and drainage. But since this is in the anorectal area, in the course of that incision and drainage, we also have to examine the patient and make sure that there isn't a cancer. And as I pointed out for the Crohn's disease, there are cases that may mimic an ischiorectal abscess. It may be a big, gigantic, fungating, necrotic tumor that has become infected, and that shows up because of infection and the pus and the redness and the heat and so on. So in the same anesthetic where one would do the incision and drainage of the perirectal abscess, one has to do the examination to make sure that it is not a cancer. There is another detail that I should add, though, for the perirectal abscess. In a normal individual who simply has an ischiorectal abscess, we drain it, the patient immediately improves, the patient goes home and has 6 baths and so on, and that's the end of that. But if we're told on the exam that the patient happens to be a brittle, advanced, severe diabetic, then it doesn't just stop with incision and drainage. In the diabetic or in other immunosuppressed patients, an ischiorectal abscess is often the beginning of what turns out to be necrotizing fasciitis, extensive, fulminating, terrible soft tissue infections. So in the vignette that would give you a bad, advanced diabetic with an ischiorectal abscess, part of a correct answer would include the close follow-up over the next few hours or next day or two to make sure that we do not overlook the development of one of these terrible soft tissue infections. We're now on vignette number 26. A 62-year-old man complains of perianal discomfort and reports that there are fecal streaks soiling his underwear. 4 months ago, he had a perirectal abscess drained surgically. Physical exam shows a perianal opening in the skin, and the cord-like tract can be palpated going from the opening towards the inside of the anal canal. Brownish purulent discharge can be expressed from the tract. This is another classic. This is a fistula in ano. A fistula in ano is a condition that can only happen to someone who previously has had an ischiorectal abscess drain. Now, I'm not implying that every patient that has an ischiorectal abscess drain goes on to develop a fistula in ano. What I'm saying is that the only way a patient can get a fistula in ano is by first having had an ischiorectal abscess drain. Now, the reason it happens that way is that the ischiorectal abscess that we talked about in the previous vignette, the way the bacteria get to the ischiorectal area is from the anal canal, in fact from the anal crypts. So there is initially a pathway whereby bacteria go from the lumen of the anal canal out into the ischiorectal area. But when these abscesses are drained, either surgically or even when they drain by themselves, the drainage is through the skin of the perineum, the skin between the anus medially and the ischial tuberosity laterally. Not surprisingly, in some patients, a tract eventually forms. Epithelial migration goes from inside the anal canal and from outside from the perianal skin. They meet in the middle, and if they epithelialize, they create a tract. They create a little fistula, in fact. This is the fistula in ano. We can do surgery for these. In fact, is a way to correct them. We unroof the fistula. Is an operation where the patient ends up, instead of having a cylinder that connects the anal lumen to the outside, it's unroofed so that granulation tissue can grow up and fill the gap. I should remind you, even though I've already said it 10 times, that in the management of a patient like this, one would also do the rectal exam, do the proctosigmoidoscopic exam to make sure that there isn't a cancer in the area. Well, we've been talking time and time again about the need to rule out a cancer whenever we have anorectal pathology. Well, actually, the vignette on the exam could be a cancer to begin with. In fact, one of those we already discussed. A patient that says there's blood coating the outside of the stools, I've had a change in bowel habit in the past month or two, that we already recognized as a cancer of the rectum, or the cancer of the sigmoid or the rectosigmoid area. The other cancer, though, that could occur in this area is the squamous cell carcinoma of the anus. Now, the squamous cell carcinoma of the anus can happen to anyone. It is slightly more common, though, in patients that are HIV positive, or also in the homosexual that is receptive in sexual practices. It does seem to have a connection with viral infection like the cervical cancer does in the female. And because it grows right very close to the anus itself, and the anal canal is often in fact felt by the patient as a mass protruding out of the anus. But there is another characteristic that allows you to make immediate recognition when you see the question on the exam. Whereas the adenocarcinoma of the rectum metastasizes only to lymph nodes inside the abdomen, the squamous cell carcinoma of the anus metastasizes also to those lymph nodes inside the abdomen, but in addition to that, to groin nodes. And so you have therefore a constellation that makes it very easy to recognize it in the question. Let me read it and you'll see it. Vignette number 27. A 55-year-old HIV positive man has a fungating mass growing out of the anus and rock hard and large lymph nodes on both groins. He has lost a lot of weight and looks emaciated and ill. Classical. This is a squamous cell carcinoma of the anus, a diagnosis of which will be confirmed by biopsying that mass that is sticking out of the anal canal. Now, what do we do for management? This is a tumor that we don't do very well if we operate right away. It's too extensive. You would have to do an abdominal perineal resection with all of the lymph node dissection that would be necessary inside the abdomen, but you would also have to do bilateral groin dissections. That's too much surgery. We do better in these tumors if we first shrink them. Now, this was established some time ago by an investigational protocol conducted by a gentleman whose last name happened to be Nigro, N-I-G-R-O. And so at the time that this was being investigated, it was called the Nigro protocol. It was a combination of chemotherapy and radiation. The chemotherapy and radiation would shrink the tumor, then surgery would follow. In occasional cases might not even be needed because it went away completely. Well, now what was a Nigro protocol at one time is now standard therapy. That's what we do in every case. This is no longer an investigational protocol, but for some reason that name stuck. So many physicians refer to the treatment of a patient with squamous cell carcinoma of the anus as the Nigro protocol. Or the exam question might call it chemoradiation, or preoperative radiation and chemotherapy, or neoadjuvant chemo, which means chemo before you do the surgery. So it's chemotherapy and radiation to begin with. If it doesn't shrink at all, maybe it's just palliation then. If it does shrink significantly, then we can do the abdominal perineal resection easier. And in a very rare case, it might in fact disappear completely and not need surgery. All right, we're going to move now to an entirely different subject. The subject now is GI bleeding, but for this particular set of vignettes, we're not now talking about the individual who is anemic and is found to have occult blood in the stool. We're now talking about the patient who either is vomiting blood or sits in the toilet and has a big evacuation that's made up of blood. So this is a gross GI bleeding. Now, before we go into the vignettes, there are some statistics that are very helpful to begin putting together in our minds where is the bleeding coming from, because that in fact is the usual challenge in a GI bleeder, is to recognize where is the source of bleeding and then do the appropriate thing for it. If you look at all the patients that have GI bleeding, 3 out of 4 are bleeding from the upper GI tract. And the upper GI tract is anywhere from the tip of the nose to the ligament of trites. So 3 out of 4 GI bleeders are bleeding from the nose or the mouth or the esophagus or the stomach or the duodenum down to ligament of trites. 1 out of 4 bleeds from the distal part of the GI tract, namely from the colon. And very few bleed in between. There are very few patients whose source of bleeding is beyond the ligament of trites but before the ileocecal valve. There are some, obviously, but it's not common. There's another item to put into this statistical thing. Those individuals who bleed from the colon, they typically bleed from either hemorrhoids, or they bleed from a polyp, or they bleed from a cancer, or they bleed from angiodysplasia, or they bleed from diverticulosis. And all of these are conditions that affect primarily the older person, particularly the last four. Hemorrhoids could be present and bleeding at a younger age, but the people who get diverticular disease, the people who get the polyps, or they get the cancers, or get the angiodysplasia, they are typically older patients. And so if we have an exam question where a 25-year-old person is having bloody bowel movements, the odds are overwhelming that the source is in the upper GI tract. If a person in the exam question, on the other hand, is 75 years old, then actually it could be from anywhere. See, the older GI bleeder is what I refer to as an equal opportunity bleeder. It could still be from the upper GI, because after all, 3 out of 4 are from the upper GI. But by virtue of being an old person who may have those diseases that commonly bleed from the colon, he could also be bleeding from the colon. Now, all of this statistical analysis, though, is completely unnecessary if the mode of presentation is vomiting blood. If a patient shows up vomiting blood, then we know already that it is coming from the upper GI tract, that the source of bleeding is somewhere between the tip of the nose and the ligamental tracts. I can assure you that such a patient could not be bleeding from hemorrhoids and have the blood go all the way upstream the GI tract and end up in his mouth. So it's got to be upper GI. And what we do when a patient presents vomiting blood is very simple. We do an endoscopy, and the endoscopy will be successful in finding the source of bleeding, because the endoscopy comes from above the site of bleeding. The blood that's coming out from the lesion goes away from the instrument that's coming down looking. Let's begin to read a few vignettes. Vignette number 28, a 33-year-old man vomits a large amount of bright red blood. Okay, this is upper GI bleeding. And the next thing we're going to do is endoscopy, and the endoscopy will find the bleeding source, and then we'll take it from there and do whatever is appropriate to stop the bleeding. In fact, often the endoscopy allows the use of things like photocoagulation and so on to stop the bleeding. Vignette number 29. A 33-year-old man has had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 20 minutes ago. He's diaphoretic, pale, has a blood pressure of 90/70, and a pulse rate of 110. Well, this is a young person, and therefore the odds statistically are that he's bleeding from the upper GI. But that endoscopy that I mention as the thing we do, it's an expensive thing to do. An endoscopy is not a trivial kind of intervention. And therefore, before we do it, we want to indeed be sure that it is coming from the upper GI. And there's a very simple way to do it. This man has presented on the vignette. It's obvious that he's bleeding right now. Just 20 minutes ago, he was in the toilet having a bloody bowel movement. He's diaphoretic, he's pale, he's bleeding as we speak. So the very first thing to do, the answer on that exam question, is to put an nasogastric tube and aspirate. When we put the nasogastric tube, aspirate, and recover blood, then we have confirmed that even though the blood is coming through the rear end, the site of bleeding is in the upper GI, and then we can follow with the endoscopy. Let me, by the way, address a question you might have at this moment. You might be thinking, wait a minute, if the blood came from the upper GI, but came out through the rectum, Didn't that blood get digested in the process? Shouldn't this patient, in fact, have shown up with melena rather than red blood per rectum? Well, it could, and indeed, if we have a vignette where the patient has melena, we know it's from the upper source that was digested. But blood can be very irritating to the GI tract. Blood can act like a laxative. And so a patient could be bleeding from the stomach or the duodenum and have such a rapid transit that the blood doesn't get to be digested sufficiently, and it still comes out red or dark red or maroon or something like that. All right, so again, the first thing to do in the patient who shows up with blood from below, and we have reason to believe is bleeding at the moment, is to put a nasogastric tube. In fact, the value of that is even greater when it excludes the upper GI as a source. Let's read vignette 31. A 65-year-old man has had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 20 minutes ago. He's diaphoretic, pale, has a blood pressure of 90/70 and a pulse rate of 110. The nasogastric tube returns clear green fluid without blood. Well, now we have reason to believe, again from a presentation here, that the bleeding is happening as we speak, because the patient just came back from the toilet having had a bowel movement, and he's got a low blood pressure and he's diaphoretic and pale. He is bleeding right now. But we put a tube in the stomach and there was no blood there. If we had been told in the vignette we retrieved white, clear fluid, we would have excluded from the tip of the nose to the pylorus. The duodenum could still be the source of bleeding, which happens in that case to be going south instead of back into the stomach. But on the other hand, if we're told, like this vignette, that the fluid that was recovered that had no blood was green. If it is green, what made it green is bile. It means we have in fact sampled duodenal contents with our nasogastric tube and they have no blood. Then obviously the bleeding is nowhere in the upper GI, and therefore this patient wouldn't benefit from having an upper GI endoscopy. We already know that it would be negative. Now what do we do then? We have excluded an upper source. Incidentally, as I talk about what do we do, I'm focusing on how do we diagnose the source of bleeding. I have nothing against saving lives, and obviously this patient with a blood pressure of 90/70 and pale and sweating needs fluid replacement and blood administration, but I take that as a given. So, obviously an exam question could be phrased in such a way that they say, what's the first thing you need to do? Well, if a patient has a blood pressure of 90/70, you need to get IVs and get fluid going and get blood going. But let's again center the discussion on how do we make the diagnosis. Now this is going to be a long discussion, so brace yourself for it. We have ruled out the upper. We put that nasogastric tube and it was clear green fluid. So this has to be coming now either from the colon, which would be a common source, or be one of those rare patients that's bleeding from the small bowel. If a patient is bleeding at a very significant rate, as this one is, it would not be productive to do an endoscopy from below at this time. In contrast to the endoscopy from above in the patient who's bleeding from an upper source, where the instrument comes proximal to the bleeding site and the blood goes away from the instrument. If we do a colonoscopy at a time that a patient has significant massive bleeding from the lower GI tract, all we're going to see is blood coming at you, blood coming at the instrument. The presence of a blood obscures the diagnostic field. So a colonoscopy is not useful. An anoscopy is, and in fact, the next diagnostic move in this individual we just read is to look at the anus and do an endoscopy. He could be bleeding from hemorrhoids. And if he's bleeding from hemorrhoids, it would be very embarrassing to arrive at that diagnosis by doing arteriograms or exploratory laparotomy or something like that. So, yes, we look at the anus, but looking beyond endoscopically is not going to be useful. So what else can we do? If a patient is bleeding at a very large rate, 2 cc's per minute or more, there is a very good chance that an emergency arteriogram would show the site and perhaps even allow embolization for therapy. How do we know somebody's bleeding at 2 cc's per minute or longer? Well, obviously we're not going to stand there looking at the rear end with a stopwatch and, clicking every minute. But we do a little simple mathematics in our mind as to how often do we have to transfuse the patient to keep his vital signs and his hemoglobin level. 2 cc's per minute turns out to be 120 cc's an hour, which means every 4 hours a unit of blood would be required. So if a patient has significant GI bleeding, the upper GI has been excluded with a nasogastric tube, and he is requiring a unit of blood every 4 hours or even a shorter time period, that individual is bleeding at more than 2 cc's per minute, and an emergency arteriogram would be likely to provide the answer. I'm not through with this yet. Okay, there are some people who would do something before they do the arteriogram. I'll get to it in a second. Let me go to the other end of the spectrum. If a patient is bleeding less than a half a cc per minute, which would mean, it takes 16 hours for the patient to require another unit of blood. At that rate, there is absolutely no hope that an arteriogram would show it. And at that rate, our best strategy, in fact, is to sit back and wait. Because if he's bleeding that, that minimal rate, we can simply provide support for the patient, wait until he's no longer bleeding, and once he's no longer bleeding, we can do then the colonoscopy that will probably find the source of bleeding. And what if it's in between? Well, let me introduce a study that is a very controversial study. Some people think it's excellent and use it in every single case of GI bleeding. Some people feel that it simply takes time and complicates the workup and doesn't really help an awful lot. And this is the tagged red cell study. Red cells from the blood bank are tagged with a radioactive substance injected into the patient, so now they are circulating in the blood of the patient, radioactively tagged red cells, and then the abdomen scan. So wherever those red cells go on puddle, radioactivity will be detectable, and by doing one of these tagged red cell scans, the nuclear medicine department can tell you if the patient is bleeding and give you some idea of where, not a precise idea, but some idea of where. If I go now to the end of the spectrum of the physicians who are very favorably impressed with this test and eager to use it, they would always use it before they would consider doing an arteriogram. So there is a school of thought that says if a patient has lower GI bleeding, we know it's lower because we have excluded with an nasogastric tube. The patient has lower GI bleeding and it's extensive, active bleeding. Some physicians say the first thing to do is a, labeled red cell study. If that study shows that blood is puddling somewhere in the gut, then we move on to do the arteriogram. There are individuals, on the other hand, who have been through this process many times in their practice and have found that many times by the time they do the tagged red cell study and they get the report and so on, the patient stops bleeding. And then that opportunity that had existed of the arteriogram showing the lesion at the time of active bleeding is lost because the patient is not actively bleeding anymore. So there is a a school of thought. There are a group of physicians who would say, if the bleeding is more than 2 cc's per minute, I'll go straight to the arteriogram. There are others, as I pointed out, who say, never do an arteriogram without first ascertaining by means of the attack red cell study that in fact active bleeding and puddling is occurring. If the bleeding is though between the 2 cc's and the half a cc, where there is no guarantee that you would have the arteriogram showing it, then a lot of people would say the first thing to do is the attack red cell study. And even in the least helpful of circumstances, the attack red cell study, if it shows that the blood is puddling either in the left side or in the right side, if that's all you can get, and the arteriogram subsequent to that, the patient is no longer bleeding and so on, it still is helpful, because if we end up having to do a hemicolectomy somewhat blindly, at least it guides us. It should be a left hemicolectomy or it should be a right hemicolectomy. Let me try to summarize this. I realize this is a very long discussion. Let me try to summarize it again. If we have a GI bleeder in the exam question that is bleeding from below, he's bleeding right now, the nasogastric tube came back clear green fluid. If it is over 2 cc's per minute, correct answers could be go straight to the arteriogram, which some people would do, or do a red cell attack study and from then go into the arteriogram. If he's bleeding below half a cc per minute, best strategy probably wait until he's no longer bleeding and then do a colonoscopy. And if he's in between those two, probably the best thing to begin with would indeed be the attack red cell study. All right, let's move on to another one, though, that gives us a somewhat similar thing, but with a different twist. This is now vignette 32. A 72-year-old man had 3 large bowel movements that he describes as made up entirely of dark red blood. The last one was 2 days ago. He's pale, but has normal vital signs. An nasogastric tube returns clear green fluid without blood. But now that negative finding from an nasogastric tube is not really helpful, because the history suggests that he last bled 2 days ago. The blood wasn't going to be sitting in the stomach waiting for an nasogastric tube to come 2 days later and identify it. If it had been positive, it would have been helpful. So if this very same vignettes had, were to say when a nasogastric tube was put, we recovered blood from the stomach, then we know it's an upper GI source. But in a 2-day-old bleed, we have no idea. The man is not actively bleeding now either by history. So it would be a waste of time also to do a attack red cell study or even much less an arteriogram when the man last bled 2 days ago. But the fact that he's not bleeding now makes the endoscopy feasible, makes the endoscopy a productive possibility. But an endoscopy of what? Well, we're going to have to do an endoscopy of both ends of the GI tract. Because even though this is an elderly patient, remember, 3 out of 4 bleed from the upper GI. And so this man needs an upper GI endoscopy as well as a colonoscopy. Both at the same session, one followed by the other. Now in the GI bleeder situation, there is one circumstance that is completely different from all the others. Vignette number 33. A 7-year-old boy passes a large bloody bowel movement. In that age group, Meckel's diverticulum leads the list. And so if that's the question on the exam, what we do is a radioactively labeled technician scan. Now this is not the red cell study. This is not the attack red cell study that attempts to identify blood puddling somewhere. This is a study with a radioactive technician that identifies gastric mucosa, which is what the Meckel's diverticulums have when they bleed. And so that's the answer for this one. There is another circumstance where the diagnosis is also pretty obvious. Opinion number 34. A 41-year-old man has been in the intensive care unit for 2 weeks, being treated for idiopathic hemorrhagic pancreatitis. He has had several percutaneous drainage procedures for pancreatic abscess, chest tubes for pleural effusions, and bronchoscopies for atelectasis. He has been in and out of septic shock and respiratory failure several times. 10 minutes ago, he vomited a large amount of bright red blood, and as you approach him, he vomits again what looks like another pint of blood. In this setting, intensive care unit, lots of stress, lots of problems for the patient, and then massive upper GI bleeding. This is invariably coming from stress ulcers. Those multiple, shallow, furiously bleeding ulcers in the gastric mucosa, usually many of them bleeding very actively. Now, this is a condition that we would rather prevent instead of treating, because the treatment is not easy. This is why, incidentally, every patient in an intensive care unit, whatever it was that led that patient to require intensive care unit treatment, is always placed on H2 blockers or antacids or both. And if you make rounds in an intensive care unit, you may find a patient that has a brain tumor, and the next one is a patient that had a Whipple's operation, and the next one had a total colectomy, and the one after that may be multiple trauma, and all of them are on H2 blockers or antacids or both, because by keeping the pH of the stomach above 4, we can prevent this deadly complication from happening. But sometimes it happens, in spite of the efforts at prevention. If it happens, obviously the first order of business is to confirm the diagnosis, because all we can tell with the patient vomiting blood is this is upper GI bleeding. It could be coming anywhere from the tip of the nose to the ligament detritus. It could be a peptic ulcer the patient had and now flared up, whatever. So we do the endoscopy. The endoscopy, however, in this setting, will probably show stress ulcers. Stress ulcers we don't do very well managing surgically. It would require essentially a total gastrectomy. And so we prefer then for the actual treatment to do it radiologically. And so we would ask our colleagues to do an angiogram and to selectively catheterize and embolize the vessels that are feeding the bleeding area of the stomach. Typically it would be the left gastric artery. We're now going to review a number of vignettes where the common theme is abdominal pain. In fact, the heading could be the acute abdomen, even though it's to a greater or lesser extent what each of these will have. The acute abdomen or the abdominal pain is actually another good example of questions that could appear in the format of an extended matching set. It provides a good common theme. The common theme is abdominal pain. And then there'll be little vignettes so that you can identify each of them, what the problem is. And we're going to, in fact, begin our review by going over the guidelines that enable us, right as we begin to read a question, to categorize what kind of a process is giving rise to the abdominal pain or to the acute abdomen. An acute abdomen, or a picture of acute abdominal pain, can be due to either one of three general groups of conditions. It could be due to a perforation. Typically it would be a perforation of the GI tract. When the abdominal pain is due to a perforation, it classically has sudden onset. It's like you turn on a switch. Sudden onset. The pain is constant, very severe, and typically generalized. The entire abdomen, receives whichever evil fluid it is that's leaking from the GI lumen. That individual that has that constant, very severe pain of sudden onset typically lies motionless in the stretcher. He doesn't want to move. Anytime he moves, that fluid sloshes around and gives him more pain. So he's very quiet, very protective, trying not to let anybody push in his abdomen. When the abdomen is examined, there will be very impressive findings of peritoneal irritation. There'll be pain to deep palpation and muscle guarding and rebound tenderness, and typically these will be all over the abdomen. There'll be no bowel sounds either, because the entire abdomen is under this extremely catastrophic situation. So that's the classical clinical picture where the problem is due to a perforation. The second thing that could lead to abdominal pain is an obstruction of some sort. A stone obstructing the ureter or the cystic duct or the common duct, or obstruction of a lumen of a small bowel. In that case, the pain is also of sudden onset. But rather than being a constant pain, it tends to be a colicky pain. It comes and goes, it comes and goes. It's a colicky pain as the peristaltic activity of the affected organ attempts to dislodge the obstruction. This colicky pain of sudden onset tends to be in a particular area where the organ is, and often has specific radiation. So it might be right upper quadrant radiating to the shoulder and to the back. It could be flank pain radiating to the scrotum, to the inner thigh, to the labia. That individual typically is moving around. The patient that has the colicky pain is looking for a position of comfort. He doesn't find it, but he's looking for it. He doesn't have that quiet, don't move, don't touch me type of appearance that the patient with a perforation has. And as far as the physical findings are concerned, they typically are located to the area where the trouble is. And they are not nearly as impressive as they would be for the patient that has the perforation. And then finally, the third mechanism that could lead to abdominal pain is an inflammatory process. All of the itis of the medical dictionary. Appendicitis, diverticulitis, salpingitis, cholecystitis, all of the itis. In that setting, the pain typically has gradual onset. It builds up to maximum intensity. In the fastest of examples, perhaps in 2 or 3 hours, and in the more typical ones, 6 or 8 or 10 or 12 hours, building up to the maximum intensity. It is constant once it is at maximum intensity, but this constant pain again is localized to the area where the problem is. So this will be right upper quadrant pain, or right lower quadrant pain, or left lower quadrant pain, sometimes again with typical radiations. The physical findings will be there, will be impressive because there is peritoneal irritation, but again will be localized to the area. So the guarding and the rebound and the tenderness and the rebound tenderness, all of that will be either in the right upper quadrant, or the right lower quadrant, to the left lower quadrant. And finally, the patient with inflammatory process, with some exceptions, but in most cases, would have also the systemic signs of an inflammatory condition, fever and leukocytosis. So with that background, let's begin to read vignettes of acute abdomen and go through what each of them appears to be. We're now on vignette number 35. A 59-year-old man arrives in the ER at 2 a.m. accompanied by his wife, who's wearing curlers on her hair and a robe over her nightgown. He has abdominal pain that began suddenly about 1 hour ago and is now generalized, constant, and extremely severe. He lies motionless in the stretcher, is diaphoretic, has shallow, rapid breathing. His abdomen is rigid, very tender to deep palpation, and has guarding and rebound tenderness in all quadrants. Classical example of a rip-roaring acute abdomen due to a perforation. We don't know exactly what the perforation is. Statistically, most likely it would be a duodenal ulcer that's perforated, but it could be a perforating tumor, It could be perforated diverticulitis. It could be a chicken bone that has gone through the wall of a small bowel. It's a perforation, that's all we can say, because it is sudden onset, it's very severe. In fact, even the circumstances that adorn the case tell you. The wife didn't have time to put on a decent dress and put on her makeup. That tells you sudden onset, very severe problem. They are there in the emergency room at 2 o'clock in the morning, okay? Now, if we find then these in the matching set, we would have to say this is an acute abdomen due to a perforation. They ask us for management. That's also pretty straightforward. This kind of a rip-roaring, clearly obvious, severe acute abdomen leads to an immediate exploratory laparotomy. As I pointed out before, we don't know exactly what perforated, but we're about to find out. As we often say in surgical circles, we're only this far from the answer. That being roughly the thickness of the abdominal wall. When we do the exploratory laparotomy, we'll find out what it is and deal with it. Now, there are one or two things we do before we do that exploratory laparotomy, because we don't want to do an emergency operation for something that might be mimicking an acute abdomen and is not an acute abdomen. This patient would always get a chest X-ray because lower lobe pneumonia can mimic an acute abdomen, an EKG because sometimes coronary ischemia can be confused with abdominal pain. Plain X-rays of the abdomen that would give us some idea, might even show the free air of a perforation, or maybe show the urethral stone for which we would not operate. An amylase because we wouldn't want to operate for pancreatitis. But again, the management is exploratory surgery. Again, number 36. A 62-year-old man with cirrhosis of the liver and ascites presents with generalized abdominal pain that started 12 hours ago. He now has moderate tenderness over the entire abdomen with some gargling and equivocal rebound. He has mild fever and leukocytosis. This is an important vignette, fellows, because we've made the point that the clear-cut, unequivocal, rip-roaring acute abdomen needs an emergency exploratory laparotomy. But if we have a vignette that as we begin to read it, the first thing we realize is this is a patient with ascites. It could be the adult with cirrhosis and ascites. It could be the child with nephrosis and ascites. When we see an acute abdomen picture in a patient with ascites, and then as we keep reading, we realize this is not a clear-cut acute abdomen. It's a wishy-washy acute abdomen. It has the pain and it has maybe some rebound, maybe not. That situation is classical for the primary bacterial peritonitis, the hematogenous primary bacterial peritonitis, for which we do not do an exploratory laparotomy. So if this is the vignette, then what you want done is a sample of that acidic fluid, do a gram stain, do cultures, because in primary bacterial peritonitis we often grow a single organism and then we treat it medically. And you would never grow one single organism from peritonitis secondary to a perforation. You would have all kinds of components of the GI flora that would be growing. Vignette number 37. A 43-year-old man develops excruciating abdominal pain at 8:18 p.m. I'm exaggerating here, but it's not 8:15, it's not 8:20, it's 8:18. And I'm exaggerating to point out this is sudden onset. The patient was able to look up at the clock and see the time when it happened. When seen in the ER at 8:50 p.m., he has a rigid abdomen, lies motionless in the examining table, has no bowel sounds, and is obviously in great pain, which he describes as constant. X-rays show free air under the diaphragm. Now there is absolutely no question. This is a perforation of a hollow viscus that contains air, namely a perforation of the GI tract. We still don't know if it is a peptic ulcer, if it is a cancer that has perforated, if it is a chicken bone that went through the bowel wall, but we know there is a perforation, and therefore the answer for the management is straightforward: immediate emergency exploratory laparotomy. Now, patient number 38, a 44-year-old alcoholic man. Wait here. If we begin a vignette of abdominal pain in an alcoholic, let's begin thinking about pancreatitis. Let's see if it pans out. 44-year-old alcoholic man presents with severe epigastric pain that began shortly after a heavy bout of alcoholic intake and reached maximum intensity over a period of 2 hours. The pain is constant, radiates straight through to the back, is accompanied by nausea, vomiting, and retching. He had a similar episode 2 years ago for which he required hospitalization. Yes, this in fact is a good description for acute pancreatitis. It's an alcoholic. The other kind of patient would have been a patient with biliary tract disease. It's an alcoholic, and the pain is epigastric, straight through to the back, so it has a location and typical radiation. It took time to build up to maximum intensity, even though it was only a couple of hours, and it's constant. This is acute pancreatitis. We're going to have a little later, in fact, a whole chapter devoted to the pancreas. So we'll go into more detail at the time on the diagnosis and management and so on. Let me just say at this time that the next move, if you're asked what do you do next, is a determination of either serum amylase or serum lipase if it is soon after the onset of the problem, or if you were told that you're seeing the patient for the first time 3 days after the beginning of the symptoms, then you would want a urinary, either amylase or lipase. We again will talk more about the pancreas a little later on. Opinion number 39. A 43-year-old obese mother of 6 children. And before we go much further, we already know what this is going to be. Because that famous lady that has all the F's, the fat female in her 40s who has 5 children, that individual we know is a person who gets biliary tract disease. So let's read again. The 43-year-old obese mother of 6 children has severe right upper quadrant abdominal pain that began 6 hours ago. The pain was colicky at first, radiated to the right shoulder, around towards the back, was accompanied by nausea and vomiting. For the past 2 hours, the pain has been constant. She has tenderness to deep palpation, muscle guarding and rebound in the right upper quadrant. Her temperature is 101, and she has a white count of 16,000. She has had similar episodes of pain in the past, brought about by the ingestion of fatty food, but they all had been of brief duration and relented spontaneously, all with anticholinergic medications. The description is in fact that of a lady that we know has a very high probability of having gallstones. She has been having episodes of biliary colic in the past, those episodes of pain triggered by the fatty food that were of short duration. She began with one of those biliary colics this time also, but this time it went on to acute cholecystitis. And we can tell, again, that this is an inflammatory process. The pain became constant, is localized to the right upper quadrant, it has a typical radiation, the lady has fever, leukocytosis. Well, we'll have a little later a whole chapter devoted to biliary tract disease, so we'll have more detail at the time. Let me just say at this time that all the workups for biliary tract disease typically begin with an ultrasound, with a sonogram. So the thing this lady needs right now for diagnosis is a sonogram. And then we'll go into more details later. In fact, we need to go into more details because acute cholecystitis, which is what this lady has, is not the only acute inflammatory process in the biliary tree. And every time we have a patient with what appears to be acute cholecystitis, we have to make sure that it is not acute ascending cholangitis. But we'll get to that a little later. Let's move on to the next. Opinion number 40. A 52-year-old man has right flank colicky pain of sudden onset that radiates to the inner thigh and scrotum. there is microscopic hematuria. Again, this one is easy. This one is an obstructive problem. It's colicky pain of sudden onset. It has a specific location, specific radiation, and in fact, you should have no trouble recognizing that this is a ureteral colic. This is a stone in the ureter. Urological evaluation, therefore, is what is needed. We could begin with an IVP, we could begin with a sonogram, we could begin with a CT scan. And I'm not going to delve into details at this time because, again, there is another set of vignettes later on that will deal strictly with urological problems, and we'll go into detail then. Vignette number 41. 59-year-old woman has a history of 3 prior episodes of left lower quadrant abdominal pain, for which she was briefly hospitalized and treated with antibiotics. She began to feel discomfort 12 hours ago, and now she has constant left lower quadrant pain, tenderness, and a vaguely palpable mass, and she has fever and leukocytosis. We can again identify that this is an inflammatory process. It took time to build up the pain. Once the pain reached maximum intensity, it's constant pain, it has a specific location, and she has a fever and leukocytosis. When we go in our minds into the differential diagnosis of the acute inflammatory process in the abdomen, once we have identified this as an acute inflammatory process, the next thought is what organ is the one responsible. For that one, we go on an anatomical basis. If the pain was in the right upper quadrant, we think of the organs who live up there. The gallbladder, the biliary tree, the liver, the duodenum, the head of the pancreas, the kidney. Well, if it is in the left lower quadrant, there are not too many things down there. Patients of either gender will have the sigmoid colon there. There's a ureter there. And then, of course, for the ladies, there will also be the tube and the ovary. We know this is not a urethral colic because the nature of the pain is not that of a colicky pain. So we know this is an inflammatory process. So it has to be either diverticulitis or salpingitis or maybe a twisted ovarian cyst or something like that. Now I'm going to suggest what is not, really a medical bit of information here, but more like a little dirty trick for examination, for that quick thinking that is needed on examinations. That of those possibilities, we should already be thinking that it's going to be diverticulitis rather than something in the GYN tract, simply because the description refers to a 59-year-old woman. And if the description had been of a OBGYN problem, I think the lady would have been identified as a 59-year-old gravida something para something lady. So the fact that we're not given those 2 items of information that always precede the description of a obstetric and gynecological problem, that's probably not what it is. Not that it really matters, because the thing we're going to do is a CT scan. In a CT scan diagnosis, the inflammatory mass of diverticulitis, it would also reveal, of course, the presence of a tubovarian abscess or an ovarian cyst or something like that. Now we move to vignette number 42. An 82-year-old man develops severe abdominal distension, nausea, vomiting, and colicky abdominal pain. He has not passed any gas or stool for the past 12 hours. He has a tympanitic abdomen with hyperactive bowel sounds. X-ray shows distended loops of small and large bowel and a very large gas shadow that is located in the right upper quadrant and tapers towards the left lower quadrant with the shape of a parrot's beak. This is actually an easy thing to recognize. Let me begin by pointing out this is a very old patient, 82. When we read a question on the exam of abdominal pain in a very old person, there are 2 conditions that should immediately come to mind. Either sigmoid volvulus or mesenteric ischemia. And then as we keep reading, we see which of the two it looks like. Well, now, as we read this one, we realize that this is an obstructive problem. There's colicky, abdominal pain, nausea, and vomiting. And in fact, we've been given a radiological description, which is classical for the volvulus of the sigmoid. I'm going to draw a little cartoon of what this X-ray would look like. This is the X-ray of the abdomen. It shows several air fluid levels like this. But the one thing that is absolutely characteristic would be this big, large, gas-filled loop that looks like this. This is a parrot's beak. That way it tapers, and this in fact is the place where the sigmoid is twisted. And then this is the big loop of sigmoid filled with gas. It comes from the left lower quadrant, but because it's on a long mesentery, and that's the only way you can get the volvulus, the actual big gas fluid, filled loop is in the right upper quadrant. So this is a classical parrot's beak that is described, which makes a diagnosis of a volvulus of the sigmoid.